Vielen Dank, Matthias. So wie ich schon gesagt, ich bin Schweizer, ich kann Schweizerdeutsch, aber ich werde einen Vortrag auf Englisch halten. Ich hoffe, das geht. So I will be talking about, can you hear me? Is it, yes. We'll be talking about psoriasis and some of the new aspects of psoriasis, including our own work. I will mainly my talk focus briefly on the introduction of psoriasis. I guess you're all familiar with it. Understanding disease burden, tell you something about the new pathogenic advances and the new therapeutic targeting. I will also show you and tell you about what we know about the different psoriasis forms and show you some special cases. And at the end, I will end with some points about comorbidities. So to start with the history of psoriasis, psoriasis has been a disease which has been known for ages. Even before Christ, by Hippocrates, it was described. And it was for a long time mistaken by an infectious disease with leprosy. In medieval times, patients with psoriasis were seen as infectious. They were stigmatized and they were forced to live at the border of society. It took until the last century, so in 1963, where it really was recognized that psoriasis is actually due to an abnormal proliferation. In the 80s, thanks to the immunosuppressive therapies targeting T cells, it has become then evident that the abnormal keratinocyte proliferation was immune-mediated, so the origin of the disease was an aberrant immune activation, which was leading to the keratinocyte hyperproliferation. And since 10 years, we know now, and we are focusing that psoriasis is not just a skin disease, but is a systemic inflammatory disease. Psoriasis, as you certainly know, is a common chronic inflammatory disease, affects 2% of the worldwide population, so approximately 125 million people worldwide. It has a chronic relapsing course. There is no cure so far, so patients deal with this disease throughout their lifetime. 20% of the patients have severe disease, defined as PASI greater than 10 or DLQI greater than 10. I'm sure you know these scores. What is really surprising is that there have been studies showing that only a fourth of these patients are actually have well-controlled disease. So there is really a need for a good treatment. And psoriasis is a disease with a lot of physical impairment. Here has been a study comparing psoriasis with other diseases. There is a score called this SF36. The lower the score, the higher the physical impairment. And you see that psoriasis gives to the patient a higher physical impairment compared to other common diseases such as diabetes, stroke, arthritis, hypertension, depression, and cancer. So it's really has a great deal of impairment for the patient. And if you look at the psychological impairment, you see that 90% of the patients with psoriasis, they are really frustrated with treatment. They fear that the disease could get worse. 81% feel ashamed of having this disease. They feel unattractive, 75%. Half of the patient, they have to deal with depression, and even 10% they have thought about suicide. So really a great psychological burden with patients with this disease. Just to show you how psoriasis is really a psychological burden, I have the example of Joseph Stalin, who had psoriasis and was treated by this Dr. Kazakov with derivatives of urine. And Stalin was so happy with this treatment that he decided to close down the state dermatology unit and to create a new institute for Dr. Kazakov to study this urine therapy. Unfortunately, this is a chronic relapsing disease, and psoriasis relapsed, and Dr. Kazakov was executed. So we all have some difficult patients, I guess. But there are other celebrities who take their the psoriasis a little more lightheaded and show it to the world, and this is the case. So the most common form of psoriasis, as you all know, is chronic plaque psoriasis. We'll be talking about chronic plaque psoriasis, which is well-demarked erythema to squamous plaques, which can be coalescent. Typical sites are knees, elbows, lumbosacral region. Those other special sites, such as the scalp, the folds, the great folds, and the palmoplantar region. If you look at histology, you see the typical changes for psoriasis with the hyperparakeratosis, the papillomatosis with elongated radial ridges, the acanthosis, so the thickening of the epidermis, and dense inflammatory infiltrate in the dermis. While years ago it was always the debate whether these epidermal changes were primary or were the consequence of the inflammatory infiltrate. Now we know clearly that it is the inflammatory infiltrate which triggers the epidermal phenotype. We know the inflammatory infiltrate is characterized by activation of dermal dendritic cells. They produce a cytokine which is TNF-alpha, which allows them to mature. These activating, maturing dendritic cells, they produce IL-23, which drives the activation and differentiation of Th17 autoimmune lymphocytes, which migrate to the dermis and produce this IL-17 and IL-22, which are directly responsible for the epidermal phenotype, which we see in psoriasis. Particularly, IL-22 drives the keratinocyte hyperproliferation. IL-17 and IL-22 alone or together, they drive activation of keratinocytes, produce chemokines, which further attract inflammatory infiltrate, and they sustain the production of antimicrobial peptides. There is an important genetic component to psoriasis. We know that 40% of the patients have a familial predisposition. We also know that if you have one parent with psoriasis, the risk of developing psoriasis is 33%. If you have two patients with psoriasis, the risk is 66%. So it becomes evident that this is not a monogenic disease, but there is a polygenic inheritance. And recently, in the past years, it has really become, some genes have been identified, become evident for genetic basis of this disease. And if you look at the identified genes associated with the risk of developing psoriasis, they all fall in this pathogenic picture which I've shown you. So we have some gene polymorphisms involving the TNF-alpha molecule. Very important, there have been SNPs found in the IL-23 gene or the IL-23 receptor gene. So this IL-23 is really key in driving the development of Th17 cells. There are other genes which have been associated with psoriasis involved in T-cell activation, such as HLA-CW6 and other molecules. And then there are also genes involved in the responsiveness of keratinocytes to the Th17 cytokines. So a series of genes which fall into this pathogenic Th17-driven cascade. So the treatment in psoriasis, I'm sure you're aware of. I don't need to go in much detail, but this is directed to the severity of the disease. In mild disease, we have topical treatments. We have phototherapy. And in more moderate to severe disease, we can use the classical immunosuppressants, such as cyclosporine, methotrexate, neotigazole, fumarates. And I would like to spend just a few words on the targeted years which have been developed during the past 15 years and who are indicated for moderate to severe psoriasis. So what are biologics? They are monoclonal antibodies of fusion protein. They target specific pathogenic events in the psoriasis. They're highly efficacious, and they don't have any direct organ sensitivity. The available biologics used now in psoriasis are the anti-TNFs. We have two anti-TNF-alpha antibodies. We have TNF-alpha fusion protein. This is Enbrel, etanercept. We also have now an anti-IL-23 IL-12/23 before the antibody, which is Stelara or ustekinumab. So you see that this targeted therapy, they really target key events in the pathogenesis of psoriasis. This is just an example with an anti-TNF antibody. I'm sure you have seen several of that. After 10 weeks, we have a very striking clearance of the psoriatic plaques. And if you look at the meta-analysis of these different biologics, you see that they are highly efficacious. You see that with infliximab, adalimumab, and ustekinumab, so this is the one that targets the IL-12/23/40. We have a PASI at about around between 67 and 80%. Etanercept seems somehow a little weak, around 50%, PASI 75. What are the new targeted therapies which are being developed, which are in phase 3 studies, and they are very promising, are the anti-IL-17 antibody and the anti-IL-17 receptor antibody. So they also fall into this pathogenic picture. And there are some really striking results. We are participating in both of these studies, I guess you probably as well. But there is very striking responses in this and very rapid responses. They seem to be more rapid than what we can achieve with the anti-TNF or anti-P40 antibodies shown here in this picture, which also makes sense because it's a really downstream event. These cytokines, as I've shown you in the pathogenic model. So here are the three. The three biologics which target IL-17 or its receptor, and what you can see here are different doses, for example, for brodalumab or ixekizumab, which also, I don't want to go into detail, but as you see, they achieve a very high PASI 75 in between 75 and 85% of the patients. So very, very effective. Just briefly, what we will have in a few years, we have already several biologic. What determines the treatment plan? I don't want really to go into details because I'm sure you're aware of that. We have to consider several points in the patient. First of all, the effectiveness. They are very effective, but we have to consider potential side effects. We have to consider the type of psoriasis. We'll be talking about that just in a minute. We have to consider whether the patient has other conditions which are key for determining the type of systemic therapy. For example, does the patient also have concomitant psoriatic arthritis? What is the impact on lifestyle? The ease of treatment and application, the compliance of the patients, and the constant insurance coverage. We have now a pretty good scheme which we adopt. So we know that our treatment regimen needs to achieve a PASI 75, so a clearance of 75% of a decrease of 75% of the PASI. If the PASI achieved is lower than 50, we have to modify our treatment. If the amelioration of the PASI is between 50 and 75, we consider the DLQI, so the psychological burden of the patient. And if the burden is very high, we have to modify the treatment. If the patient accepts this situation to have just a partial amelioration, we can keep on with the treatment. What are our modification strategies? We can increase the dose, reduce the dosing interval, adding either a topical or systemic drug, or changing the biologic therapy. So what are the early triggers of psoriasis? You know, the trigger factors of psoriasis are typically external factors, what we call the Koebner phenomenon. So skin wounds, mechanical skin frictions, scars. But there are also systemic factors such as drugs. A typical drug is the beta blockers, for example, that can trigger psoriasis. Infections, HIV, streptococcal throat infection. but also psychological stress. And we have been looking a little bit more in detail. That's our main focus of research, and we have helped to identify a little bit the early events that are responsible for triggering psoriasis. I have presented also yesterday this in my talk. We know and we have demonstrated that upon mechanical stress, upon Koebner phenomenon, the antimicrobial peptides, which are induced to protect the skin from microbial invasion, they form complexes with extracellular nucleic acids released in the context of cell death, for example, during the mechanical stress. And these complexes are able to activate a unique set of dendritic cells, which are called plasmacytoid dendritic cells. And these cells are specialized in producing cytokines, which are called type 1 interferons. And these type 1 interferons are potent initiator of inflammatory responses by activating dendritic cells and triggering this cascade, which I've presented you. So we think in the acute phase of psoriasis induction, this pathway is a key pathway, which then drives the chronic phase of inflammation. We also know that the Th17 cytokine are directly responsible for sustaining the expression of antimicrobial peptides. That's a key feature in psoriasis. And these antimicrobial peptides then sustain the innate inflammatory activation and the downstream autoimmune inflammation. So, are there any gene defects which could explain these innate pathways? Yes, so in 2008 and 2012, there have been some copy number polymorphism identified for these antimicrobial peptides, in this case for the beta-defensin, which could explain why we have an enhanced production of these antimicrobial peptides, which could explain the downstream inflammatory response. Furthermore, we have genes which are associated with this interferon signaling. We have this SOX1, which is a suppressor of type 1 interferon signaling. We have TYK2, which is a tyrosine kinase, and we have other interferon-induced genes which have been associated with psoriasis, which validate our model that I've just presented you. And this is the summary. So before I showed you this pathway with the different gene polymorphism involved in the activation of Th17 cells, but now newly identified polymorphism are also involved this interferon response and the expression of antimicrobial peptides. There are efforts being undertaken to develop molecules which target this early innate type inflammatory pathway, such as these molecules, anti-BDCA2, anti-LT7, which can target directly human plasmacytoid dendritic cells, inhibit their activation of produced type 1 interferons. Two companies are developing TLR7 and 9 inhibitors, which is the receptor which activates plasmacytoid dendritic cells. These are in both companies in phase 2 studies for psoriasis, and we have an anti-interferon alpha antibody, which has been tried in psoriasis, but is mainly now developed for lupus. So what are other forms of psoriasis? We have guttate psoriasis, which is, as you know, the more acute type of psoriasis. We have erythrodermic psoriasis. Why I'm mentioning that? Because we did some gene analysis in these types of psoriasis, and to make a long story short, we found that these guttate type psoriasis or erythrodermic psoriasis are more related to high interferon induction, so they are more a acute type psoriasis compared to the plaque type psoriasis where we have a high expression of TNF-alpha. I will come back to the pustular type psoriasis, which is mainly related to IL-1 beta expression. But I would like to show you some other cases which illustrate this early innate type interferon-driven response. So you're probably aware of the fact that patients under anti-TNF therapy, they can develop what is called paradoxical psoriasis. So we know this is actually in 5% of the patients that receive anti-TNF treatment, either for rheumatoid arthritis, for Crohn's, but also for psoriasis. They can develop these acute psoriasiform lesions, which we call paradoxical psoriasis. So we have collected a whole series of these patients, 25 patients, and analyzed it a little more in detail. So we see that the different anti-TNF agents can induce it. We did not find any, it's important, any of these paradoxical psoriasis in Stelara treated patients. That's also key. So it is really a disease which occurs under anti-TNF treatment. So when we looked at the skin lesions, I've shown this picture yesterday also, we see a massive infiltration of plasmacytoid dendritic cells. When we compare the number of plasmacytoid dendritic cells compared to classic psoriasis, we see that we have many more of these cells in this paradoxical psoriasis. When we do a gene expression analysis and compare classic psoriasis to this paradoxical psoriasis, there's no change in TNF on IL-23, but what is striking is that we have very high expression of type 1 interferon genes. IL-12 is the same, IL-8 is the same, IL-1 beta is the same. So what do we know? We know that from the immunology literature, this is mainly work done by Jacques Pancherot, that developed this concept of the yin-yang of interferon and TNF. So basically interferon and TNF, they are at an equilibrium. If we treat the patients with anti-TNF, this equilibrium is shifted towards type 1 interferons, and if we have a trigger, such as Koebner phenomenon in this patient, we have an interferon-driven inflammation with the development of this paradoxic psoriasis. We've also confirmed that, and I'm not showing you data in mouse models, where really this type 1, this anti-TNF treatment can predispose to the development of these psoriasiform lesions. What is important to know, this is not real psoriasis, because these patients, when you take them out of TNF, they never develop the psoriasis again. But what is important in this case is the management of this patient. You have to stop anti-TNF. Don't switch to another anti-TNF because it will do the same. We have to either classic psoriasis treatment. What we do often is to switch to another class, such as Stelara, which does not induce this. Future could be to use these anti-interferon and inhibitors of TLR7/9 to treat these patients, or even to prevent the development of this case. Another example here, this was a patient, female, 56 years old, with a psoriasis since '98. So she was under methotrexate from 2005 to 2012. What is important here in this patient is that she had a concomitant cutaneous lupus erythematosus since '96. No systemic symptoms. She had a plaque anil, and she's in durable remission. So here's the picture. So it's not controlled under methotrexate. Just some pictures here. So what would you do? What is important is history, and is related to what I've shown you before with interferon. We know that lupus is an interferon-driven disease. So we absolutely, and this is also well known, and it's the explanation for that. We should not give any anti-TNFs in lupus-prone patients. So what would you give? We give ustekinumab, Stelara, with a complete clearance. So we know that this anti-IL-12/23 antibody does not develop any paradoxical psoriasis and does not develop any lupus-like syndrome, which makes sense because this interferon-driven pathway is enhanced only by blocking TNF-alpha. The third case I would like to show you is a patient with chronic plaque psoriasis and palmoplantar pustular psoriasis since '64. He had multiple therapies. I'm showing this, and probably you also have cases in your cohort. The patient was treated with anti-TNF therapy with a very excellent response to plaque psoriasis, but he had anti-TNF resistant palmoplantar pustulosis shown here. So what would you do? So we added acitretin to our anti-TNF treatment with a good evolution in this patient. But this example helps me to go to the next topic. So what is pustular psoriasis? Is it really a distinct form? Why didn't it respond well to anti-TNF? Here different forms: systemic, generalized psoriasis, pustulosa, or palmoplantar pustulosis, or acrodermatitis suppurativa continua, Halopo. So we looked at pustular psoriasis, and what we found here, we looked at interferon alpha and IL-1 beta, for example. We did many more genes. And what was striking is that these pustular psoriasis, they really have enhanced expression of IL-1 beta compared to the chronic plaque psoriasis. As I've shown, it is more TNF-alpha driven. The acute psoriasis I've shown here is more type 1 interferon driven. And an interesting recent study by Bachelet has studied familial generalized pustular psoriasis from a Tunisian family. And what they found is a missense mutation in an IL-36, so a new cytokine receptor antagonist. This was very interesting. So what is IL-36 and what is the IL-36 receptor antagonist? IL-36 is part of the IL-1 member. It has 3 members, so IL-36A, B, and G, which activate the IL-36 receptor. This triggers an FKB activation MAP kinases. We know that there is this IL-36 receptor antagonist, so an antagonist for the receptor which antagonizes IL-36. So this is the gene which was identified, a mutation in this gene was identified in this familial GPP. So this is the way it works. So we know that IL-36 activates its receptor, which triggers this NF-kappa B and MAP kinase activation, which directly leads to expressed in the receptor is mainly expressed in keratinocytes, which triggers expression mainly of IL-1 and IL-8, which recruits neutrophils. So what the IL-36 does, it blocks the receptor, competitively antagonizes IL-36. And you can imagine if you have a mutation in this a loss of function mutation, you have an enhanced activation of NF-κB and MAP kinases and enhanced production of IL-1 by keratinocytes. And the same group, so this is Bachelet in Paris, they also showed that GPP can actually be treated by an IL-1 antagonist. So this was a GPP patient which was not responsive to anti-TNFs, but showed, as you can see here, after 4 days after an Anakinra injection, a dramatic response to this IL-1 blockage. They also searched whether there was a defect in the IL-1 pathway. They could not find it. So this is just again suggestive what we found, that IL-1 plays a key role in these pustular type psoriasis. So we like to simplify and put up the following scheme. We think chronic plaque psoriasis is really a TNF-alpha driven disease. We have these acute forms of psoriasis which include psoriasis cuttata, unstable psoriasis, erythrodermal psoriasis, or this paradoxical psoriasis, which is type 1 interferon driven. And on the other end of the spectrum, we have this pustular form of psoriasis, which are driven by IL-36 and that drive directly IL-1 expression. I think it's a nice model to keep in mind also that can guide you guide us in our clinical strategies. Just at the very end, I like to spend just 2 words on comorbidities. I cannot pass a psoriasis talk without at least mentioning psoriasis arthritis. I mean, you're all aware of that. I'm not going to spend many words on that. So 10 to 30% of psoriatic patients have psoriatic arthritis, debilitating joint inflammation, predilection sites are distal interphalangeal joints, asymmetrical distribution in peripheral joints. usually, we always have to ask patients and investigate whether they have psoriasis, arthritis. Usually skin involvement precedes the joint involvement, so the diagnosis is easier, but we have to consider that in 20%, actually the arthritis precedes the skin involvement, so in that case, the diagnosis is more difficult. And as I mentioned, in the past 10 years, it has really become a big field of interest. That we know now that psoriasis is really a systemic inflammatory disease in which we have associated high blood pressure in this patient, a metabolic syndrome, obesity. The patient have really a hard time to control their weight. It can be associated with Crohn's disease. The same type of susceptibility genes have been found in Crohn. As I mentioned to you, 50% of the patients, they have problems with depression, have or more likely developed diabetes or heart disease. And a study by Gelfand showed that patients with severe psoriasis are really at increased risk for heart attack, and mainly at young age, as you show here, age 20, 30, 40. You have patients with severe psoriasis have increased risk of myocardial infarction compared to the control population. Very important to know. And another interesting study I find recently published by the same group of Gelfand did some PET scan. And what they found is that the radioactive glucose is not only found here, you can see the plaques, psoriatic plaques in the skin, but it really also lightens up in the arteries, really indicating that these patients have a systemic disease with inflammation in the arteries, and really raising the awareness that this is a systemic disease which needs absolutely to be treated. And indeed, there are recent evidence that systemic therapies such as anti-TNFs, they have a beneficial effect also on inflammation of the blood vessels. This is my concluding slides, just to put you up some recommendation for the Psoriasis Foundation Medical Board. So for our patients, if you smoke, quit smoking, moderate your alcohol intake, try to have a healthy diet, exercise 3 times a week, and for people with moderate to severe psoriasis, start screening for cardiovascular disease starting at age 20. Monitor and modify cholesterol levels if necessary, and importantly, take measures to control depression because this is associated with psoriasis. And with that, I'd like to conclude, and thank you for your attention. I'm happy to take your questions.